This is turning into a great talk. I'm really enjoying this.
Yes, this is the podcast, Dr. Moliver, that I talked about, like this kind of laid back conversation, like being real. I think this is what is missing.
Welcome to the Doc Moliver podcast, plastic surgery, science, and cool stuff in between.
Hello and welcome everyone. This is Tamara from Plastic Touch, and today we are speaking about untold truths of plastic surgery, what happens behind the scenes, complications, and real life. So today with us is Dr. Clayton Moliver, his surgeon, his professor. Doctor, welcome. Could you tell us how long have you been doing this job for and what kind of surgeries you mostly perform?
Okay, so thanks for inviting me. I really enjoy teaching, as you know, and I enjoy being in front of the camera a little bit as well. I've been a plastic surgeon for 30 years, actually. I started in 1992. I did general surgery training, so I did a full general surgery residency, which doesn't happen very much anymore, but I really enjoyed it. So I operated all over the body. And then I did a plastic surgery residency and finished that in 92. Here in Houston, Texas, was where I'm situated. That's where I practice. So I've been in practice for 30 years. I did a lot of breast reconstruction early in my career. I did a lot of tram flaps and free tram flaps and a lot of trauma reconstruction. But I've been doing only aesthetics for the past 20 years. I do a lot of everything. But in the past, I guess, 5 or 8 years, I've dropped off rhinoplasties, for example, because I just didn't feel like I was doing a lot of them all the time to give my patients really the top-notch, cutting-edge kind of results and techniques. So these days, I do a lot of breast surgery. I've done over 10,000. We checked with our implant manufacturer, over 10,000 breast augmentations. I couldn't believe it. But I do a lot of breast revisions and breast lifts. I have a sub-niche, a specialty in symastia repair, and we can go into that later if you like. I do a lot of body contouring and tummy tucks, and I do some facelifts. My partner, Dr. Fred Aguilar, is really well known in our area, and he does a lot of facelifts. So more and more, I'm deferring some of those to him.
So you do mostly breast surgeries now and kind of liposuction, abdominoplasties in the past couple of years.
That's where it is right now. A lot of breast surgery, a lot of revision breast surgery, and a lot of body contouring, liposuction, tummy tucks, bra line lifts, brachioplasties or arm lifts, all those sort of things. Yeah.
So we see a constant debate in our comments on our page. So there are patients that come to you with different BMIs. Some are in the healthy range, some are overweight, some are obese. And is it safe to perform abdominoplasty on these patients, as we know that they have higher blood pressure, heart rate, blood supply regulation works differently. So is it actually safe to perform these surgeries, and are rates of complication higher with overweight patients?
Well, that's a great question. I think as a plastic surgeon, as a physician, you have to assess each patient individually. I'll veer off for just a moment, then I'll come back to overweight patients. Patients come in sometimes, they're 65, they're 70. Am I too old for this surgery? Well, we know that 65 and 70-year-olds get facelifts all the time, so why shouldn't they get other skin surgeries? We're not inside the abdominal cavity. We're not inside the chest cavity. So it's not quite, the kind of catastrophe kind of things that can happen, although they can, of course. That said, overweight is another issue entirely. We know for a fact that as the BMI, the body mass index, goes from 30 to 35 to 40, that we're on a curve that starts getting very steep, and with respect to increased wound complications, pulmonary emboli, out of control diabetes, big fluid shifts, things can go bad in a hurry. And so that's a problem. The other thing I look at in patients is, and occasionally I will deviate from my rules. So I've got a hard rule: 35 BMI and over, I won't operate on you. Between 30 and 35, it will be a little bit different for a couple of reasons. One, I'm looking at compressibility. Now we're talking about abdominoplasties. I'm looking at compressibility. Is the abdomen soft? Can I compress it? Because when we lift the skin envelope up and we want to plicate or sew in the muscles, we can't do it very well. And when we can wind up with sutures that tear out, et cetera, if the abdomen is very firm. So one of the things I'll do when I examine a patient is I'll check, is their abdomen softer and compressible? Some people carry their weight in their abdomen. Men tend to carry their weight intra-abdominally, visceral fat. Women, not so much, except sometimes they do. Everyone's a little bit different. Some people have a pear shape. Some people carry it all in their abdomen. They have skinny arms and legs. So we really have to individualize. And then another topic along those lines that I really love talking about is women of color. You have a Black woman or man come into my office, and the BMI, I might look at the chart before I walk in the room, and I'm saying, oh, the BMI is a little high. I'm going to have to talk to them about diet and weight. And I'll talk to them about those things and say, please come back in 3 months. Let's see you. But a Black person, a woman of color, oftentimes will have a higher BMI and not fit the stereotype of, oh, they've got a 33, a 34 BMI. They're going to be very obese. And you go in and they're actually very muscular and they're not very obese.
So body composition matters. Yeah.
Exactly. Their body composition matters. So you really have to sort of individualize it. But with a broad stroke, with a broad brush, the heavier you get, the more complications. It's the truth.
Thank you very much for being honest. And as you say, these patients should maybe try to lose weight first, then come back to you after 3 months. So is it more likely for these overweight patients that get abdominoplasty to come for round 2 after, since they maybe haven't established healthy lifestyle or habits?
Well, I'm not sure where you're going with that. I think there's 2 topics to talk about. I like the fact that oftentimes, even though I'll spend some time with the patient and I know I'm not going to operate on with them, that, we'll bond, they'll feel like I'm concerned about them. We send them an email with a couple of different weight loss diets that I've found really work. There's now great medications, Wegovy and others that you can inject, and they really help with weight loss. A lot of people are doing that. So they will come back for their surgery later. Sometimes I'll just do that lower abdominal flap of skin in a heavier patient and not do the big abdominoplasty, just to make their hygiene better, their self-esteem better, to clean things up. And maybe they'll lose weight and we'll come back later and do, quote, round 2 and do that full abdominoplasty. But the other topic that's worth mentioning is doing that operation, liposuction or a tummy tuck, which is all superficial. It's outside the abdomen on someone who's overweight. You really shouldn't be doing it. And they come back 5 years later and they say, I need more liposuction, more on my tummy. And you feel their tummy and there's about that much fat or tissue over their abdomen, but their abdomen's gotten bigger. So once that fat is gone from the abdomen, and you've done liposuction to the hips, people talk about, well, does the fat come back someplace else? Yes, it does. It comes back on the shoulders, on the hips. Now we have cankles. But it comes back intra-abdominally, and that's really bad for you. And so, sometimes I see a young person and, they really want to get liposuction. And those in particular, I'm looking and I'm saying, oh my gosh, you're 18, you're 22, you're 24. What did you gain weight when you graduated high school? What were you when you 2 years after, 4 years after? And you want liposuction? And I can see the whole thing. I can see them when they're 20 and 25 and 30 and 35, and they're 2 or 3 pounds a year or 4 pounds a year, which turns into 20 or 30 or 50 pounds in 10 years. And I'm doing them a horrible disservice by saying that. And so sometimes I'm kind of rough on them. I'm saying, hey, you need to get things in order here. We need to get more sleep, more exercise, clean eating. So, they say plastic surgeons are psychiatrists with knives. We have a unique opportunity to get very personal with people in a hurry. And I kind of like that. I mean, it's an amazing opportunity. Normally, nobody gets that personal with someone. So we can affect some people if they're receptive. So it's a nice opportunity to make a difference, I think.
And on the other side, how many of your patients actually keep their results long-term throughout the years?
I've been in practice a long time, so I've got a good vantage point to look at that. And they do. I mean, maybe it's because I select well, and I don't select people that are really overweight that come back for their, sometimes we see people that come in and they're hopping from plastic surgeon to plastic surgeon, and already had their breast reduction. They've already had their tummy tuck. They've already had their liposuction on several episodes. And they're just treating obesity. But in my patients, I think because I've held the line, I tried to educate, I have tons of patients that come back and the tummy tuck's doing great, Dr. Moliver. Thank you so much. I'm ready to, reduce my boobs or, my breasts. The big implants were great. They were a lot of fun, but I'm ready for smaller ones. I want to lift. Let's do my face. So it does. I did a tummy tuck on my wife 25 years ago. It still looks great, but she's an athlete. She stays in shape and she still looks
and
good.
She's next to you as well.
I keep an eye on her. She keeps an eye on me.
Yeah. So why surgeons never publicly speak about complications that happen to their patients? Anyone who says they don't get complications is not telling the truth. So why is it like this? Why is it taboo?
I think it comes down to marketing. We're very afraid that if we show a complication, people are going to say, I don't want that happening. I'm not going to him. And it's hard to get across in that short interview or in a marketing kind of event, being on social media, that number one, it happens to everyone. And number two, because it happens to everyone, meaning plastic surgeons, general surgeons, we have complications. Things go awry. You can't always control it. Sometimes it's the patient's fault. Sometimes it's our fault, and it's just unfortunate, and people say, well, it's malpractice. Well, there's a difference between malpractice and an unfortunate outcome. Complications, they do happen. And one of my professors many, many years ago, a guy by the name of Ben Cohen, great teacher, he said to me, hold your patients close, hold your complications closer. And I've tried to pay attention and do that. And I'll tell you, I've cried with my patients, literally cried. I hold them closer and I see them through the process. And I'm not trying to, tout myself or toot my horn, but many people are ashamed. They're ashamed to have plastic surgery. They're afraid people will judge them. Fortunately, I think we're moving into an era where we're trying to get out there the idea of let's not be so judgmental, right? That's not the way I would live my life, but I'm not going to judge you. That kind of concept is more prevalent now, and people are getting more educated with social media. So I'm starting to put things out there and saying, we've got a few we've shot, and you guys are going to put it up soon. I had this complication. We had this complication, and I was heartbroken. She was heartbroken. But with patients that are reasonable, they know these things happen. You just have to get them through it and see the process. And I think patients that are educated and thoughtful are going to see that and say, okay, that's going to happen. And at least this surgeon is going to be honest about it and see it through. But, you see some websites and, it's only perfect results, whether it's Photoshop or anything else. That's another whole topic. But, we want to show our best results.
And have you ever told your patient not to worry, everything's gonna be okay, and in your mind you were thinking like, oh my God, this is definitely not good? So do you show your patients that you're worried about something, or you don't want to scare them?
I think that's a case-by-case basis. You really have to read your patients. Some patients are very anxiety prone. They have a white coat syndrome. And, any little misstep in how you speak and the words you choose, they're going to jump on them. I'm going to be getting phone calls every day, and they're going to be anxious. And so I think as physicians, you're brought along to be very confident and very supportive. And even though we're going down a road that might have some problems, they might not be ready to hear it quite yet. And you have to judge when it's okay to start introducing, look, I think we're going to have to tweak this breast. I think we're going to have to do a little bit of liposuction or fat transfer. I would like to get that on the table as soon as possible, and get it out of the way and be very transparent. But sometimes you have to just walk delicately and be caring that you don't frighten someone. So it's a dance,
That is good. And as you said, you are a psychologist as well. You have to read people, see how they react, and just be very careful with patients.
Years ago in plastic surgery, they would actually ask people to fill out a form, which was a psychology evaluation form. And if they fell into certain categories, we were taught, don't operate on this person because they're not going to react very well. We don't do that anymore. But most of us are assessing the patients. And I like to say that, I'm interviewing the patient to see, are they crazy? Are they very insecure? Are they very particular? I often say, so tell me, when you leave your house in the morning, do you straighten all your pillows? No one's going to be there, but you straighten them all. And I get a lot of patients saying, oh yeah, that's what I do every morning. That's not a I can't operate on you thing, but it informs me on, are they very, very particular? Expectations in aesthetic surgery are everything. There might be, no two breasts are alike, where, they're sisters, they're not twins. Some people will accept the fact that there's going to be mild changes one side or the other. Some people won't accept it at all. Some people want perfect. Perfect scares the heck out of me. So I'm listening for every word. I'm listening to it. But as much as I'm interviewing them, I expect them to be interviewing me. I might not be the right doctor for them. They may need someone else, someone who's less direct. My patients tell me all the time, or they talk about me, he's very direct. I think that means I don't pussyfoot around. But,
I think that is good, actually. So they know exactly what's going to happen, what should they expect. And could you tell us what was the scariest complications you had, or some scariest moment in surgery that happened to you?
Oh, gosh. In plastic surgery, you have to understand, in my early training, I was at a level 1 trauma center. And for 1 year, I was the chief resident. And because it was a smaller program, but still a level 1 trauma center, it was in El Paso, I was the only chief resident for an entire year. So I had horrible, gunshot wounds to the chest and just terrible, terrible injuries that I took care of. And those were scary, and people died, but it's a whole different thing. In my current life as a plastic surgeon doing aesthetic surgery, thank God I've never had a death. In fact, I think we've had one patient have to go to the hospital in 25 years, actually get admitted, and she wound up being fine. But I had one episode just a few years ago where the patient went into heart block, and we were operating on them, and I actually had to do CPR on the patient. Turns out that we transported her. Well, we transported her to the hospital. She stayed overnight, and they said she's fine. She just was in athletes. They can have a very low blood pressure. I think she was partially an athlete, but she partially had some sort of cardiac electrical abnormality. But it wound up being fine. We wound up, operating on her about 3 months later, and as the cardiologist treated her and whatever. But it turned out to be nothing dangerous. But she dropped her heart rate to like almost nothing, and I had to start CPR. It scared the hell out of me. Because her heart rate was dropping, and that does happen in some people, but as long as their blood pressures are okay, or the anesthesiologist can maintain it, it's fine, and they usually come out of it and everything's fine. But she wasn't coming out of it, so that scared me. But I think when you go through training, people sometimes say to me, well, how do you stay so calm when things aren't going so well? With enough years of training, and training like I went through, you sort of adjust to sort of slow down the gears a little bit to take care of the problem correctly. Sometimes you see people just get all excited, and that doesn't help anybody. So.
Yes, that's just what I wanted to ask you as well. Sorry to interrupt. So surgeons learn new things throughout the years. And could you explain to us, how did you feel when first time in your life you experienced some complication or something unexpected? Were you nervous or were you calm, as you just told us?
Well, I think this is a transition. I went through 6 years of general surgery training, and early on, you get called to a code, and you're the junior person on a code group, and you're excited and you're nervous and you're running, and they're saying, okay, Clay, your turn to start doing this. You have to put a chest tube in, you have to do CPR, you have to open the chest. This is kind of gross stuff for a lot of people listening, but that's what we did. We're trauma surgeons. And your heart races and you get pretty nervous and excited. And then as the years go on, you see so much of it. I don't think you get numb to it, but your brain changes in how you approach this, and you just get more methodical. One of my professors, I was running to a code. He said, "Don't run." I said, "Well, it's a code." He said, "Walk." quickly, don't run. I think there's probably a time to run. But what he was trying to say to me is gather yourself, focus. You'll do a much better job than running. But as far as, I had several in my trauma years, especially. I had a little girl that was perhaps, I think, 8 years old. I don't want to go into details, but her sister got in the car a little bit older. I think she was 12 or so, and her parents let her start the car, and she accidentally threw it in gear. And it was a terrible, terrible accident. And the other daughter was outside the car. It was terrible. And she came in, and we lost her in the emergency room. And it was just, I literally went outside and cried. It was just so heartbreaking. I'm getting teary now.
Yeah, me as well. This is a very, very sad story.
And then there was another one where a gentleman had a horrible, horrible car accident. We were able to get him to the operating room, but we lost him on the table. And I went out to talk to his identical twin brother.
Oof, yeah,
that was pretty painful. There was others, but those were two that jump out at me.
Yeah, that you remember that strongly affected you.
Yeah, they stay with you. And I did trauma surgery for a short time. I can't imagine people that do it all the time in big cities and big, places.
And every single day, different cases. So it might be hard for your mental, but you have to be strong, and surgeons see things every single day. While we're talking about it, could you tell us what affects?
Well, let me back up. As a plastic surgeon, people don't realize that we are still doctors. And so you think of us as, oh, I'm going to do a breast augmentation. Oh, I'm going to do a facelift. But if you keep your wits about you and remember you're a doctor, I mean, unfortunately, as you get more and more specialized, you sort of put blinders on. You just don't even see the other stuff. But there's been, many cases where someone's come in and I've walked out of the room and said, oh my gosh, that person's got cancer. I examined someone's breast and it's like, that's a very suspicious mass. And, there's been many cases where I've caught it early and referred them on, and that's been gratifying. But you still have to be a doctor. You still have to look at things. I've diagnosed people with all kinds of things. And most of us have, because you see someone and, they're jaundiced or they've got a big belly, and it's not because they're fat. They've got a big ovarian tumor, or they've got ascites, fluid in the abdomen. So, we still see people every day, and they come in for one thing and it's not that at all. It's something completely different, and you got to send them back and get them worked up and get them treated. So you can't just kind of blindly say, oh, you came in for a tummy tuck, let's do a tummy tuck. That there's practices in our country where, I swear to God, this is true. I'm appalled by it. But you actually call in or come in and you're seen by a patient coordinator who schedules you for surgery, and you meet your doctor the morning of surgery. That happens, and it's horrible because we're still doctors. We have to evaluate people, and sometimes they think they need this, and you look at them and say, that's not what's going on at all. It's this. So,
what affects surgeons' performance? So if you're feeling that day nervous, sad, you're just not feeling like doing the surgery, does that affect the outcome?
That's a great question. And let me put it to you this way. I think there's a couple of areas that I think I'm very cautious about, and I think do affect a person. It doesn't matter how many years you train and how you're good at it. A microsurgeon can sit there for 6 hours and do microsurgery. As you get older, that ability gets less. What we do is hard. We are very physical. We're doing liposuction. We're bending over and twisting to look under into a breast, into a tummy. And, over the years, that can wear on you. I go to the gym 5 days a week and I run to stay fit so I can lengthen my career because I love what I do. So being fatigued absolutely hurts what you're doing, because people tend to say, that's good enough, instead of saying, it's not quite how I like it. I think I need to take down those sutures and redo that one little area, take a little bit more tissue off that breast, take that implant out, put this implant in, set them up. That looks better. But let's face it, if you've been at it for 10 hours, you're going to say, that's good. That's fine.
Yeah.
And then the patients come back and they come to me, and I'm sure it's happened to me too. But what the patients say, is, Well, the doctor kept on telling me, it'll be okay. It'll be okay. Just wait. It'll be okay. It's got to drop in. The swelling has to go down. And, we're 4 months out. We're 6 months out. It's like, it ain't changing. There's a problem here. And, whether it wasn't recognized, whether they were going too fast, trying to get more cases in a day, we're a little bit in retail medicine, right? And if we do 3 breast augmentations in a day, we make money. If we do 5, we make more money. If we do 10, we can make even more money. Oh, heck, let's go around the clock. Well, there's some doctors that literally operate till 7 and 8 at night. You're fatigued, you're tired, you're not doing your best work. It's just, you're not as focused. There's certainly that part of it. So in some countries, they don't let you operate. They say, nope, you can't be a doctor, you can't be a surgeon past a certain age. Friend of mine in Switzerland had to retire after 65. They said, sorry, we know there's cognitive decline. Is there in everybody? No, but there's enough that they feel like they just got to draw the line. So, what we do, it's very important, the decisions we make and how we do them physically. So let alone, people that get in trouble with drugs, they're partying all night. I go out with my friends. I say, sorry, it's a school night. I got surgery tomorrow morning. I'm not drinking, or if I am, I'm having one small
You're
drink.
You're not going to risk it.
You can't risk it. And, for someone, this is like the biggest, one of the biggest events in their life, their mommy makeover. And you're out till 11 o'clock at night, having a great time with your buddies, and you don't get enough sleep, and you get there in the morning. I mean, that can't be good, right? I mean, we know that intuitively, we know that. So
yeah, for sure. So have you ever canceled someone's surgery on surgery day because you weren't feeling well or something happened? What was the reason for it, if it ever happened?
Well, I don't get sick very often. My staff knows when I call in and say I'm not coming in, that's like twice in a career. I mean, it's like that's how often it's happened. Really bad flu or something. But if I've got a cough, if I've got a cold, I'm going to work. I mean, take some antihistamines, do what you have to do, and take care of things. So there's that. On the other hand, we've canceled plenty of surgeries. Oh, my dear, you're pregnant. We can't operate on you. Do a pregnancy test. Oh, your nicotine test came back positive. I know that you say it was just secondhand smoke, but that doesn't really happen. You're positive. In some cases, I can go ahead, depending on the surgery I'm doing. In some cases, we're not doing it. So there's various reasons. People come in and say, okay, you were NPO, you didn't eat, right? It's like, no, I had breakfast this morning. Okay, you're canceled, So sometimes patients just don't do what they're supposed to do. So there's the patient end of it, and there's the physician end of it. I don't cancel very often for me because I'm extremely motivated. I mean, I'm a type A personality. I mean, I'm very regimented, but.
And how many of your surgical results, maybe in percentages, you can say you are happy with them? You can tell yourself, "Ooh, I've done such a good job here."
Oh, that's unfair. We're perfectionists, if we're really, really, really honest, it's a smaller percentage than we'd like to admit that are perfect. I don't know. I don't know. I can't answer that. I'm not going to answer that one.
Yeah,
because you can always critique. If you're honest and really honest with yourself, you can critique it and say, that could have been a little bit better. I mean, I don't know how many times I've walked into a room. This happens to every surgeon. If there's any surgeons listening to this, they'll say, oh yeah, that's what happened. You ask how many times what percentage are perfect, are just the way I want it. And my answer to that is a common story. And that is, you walk in to see the patient and they go, Dr. Moliver, I'm so happy. This is so great. It's such an improvement. And you look at them and you go, I think we can do something here. And they go, oh, really? And I think we can improve this and blah, blah, blah. And, whichever way it goes, maybe they say, no, I don't care. Maybe they say, okay. And you walk out of the room and your nurse looks at you and says, really? Really? Did you have to say anything? She was totally happy. And you're picking at something little tiny. Shut up. Don't say anything. She's fine. Or he's fine, or whatever. Every surgeon can relate to that. So
no results are perfect. You're going to achieve best possible at the given moment. So we know that surgeons' technique, patient's genetics, post-operative care play the most important roles. So how much does it truly depend on you, and how much of the rest of the factors?
Well, there's a little ego thing here. I'd like to believe that a lot of it depends on the surgeon. I try to be as meticulous as I can. I'm very proud of my suture lines. I started practicing that when I was a medical student. Go to the emergency room, sewing. But you're right, and you're very astute. And you've been doing this a while, so you know the lingo, you know the dialogue. I mean, some of it's genetics, right? You have Black patients, you have Asian patients. Very challenging because they can form very thick scars, no matter what you do. In the best of hands, they can form hypertrophic scars. Having said that, I revise a lot of people's scars because, frankly, there's some people that just rush it along, or they're not closing, or they're not paying attention to all the surgical principles we know. Wounds under tension tend to be they widen, or if they're not closed with enough layers, they tend to dip in or they widen. If in people of color, if you don't get the skin edges just right and one edge dives into the other, well, that epithelium keeps on growing and that forms thicker scars. So, is there diabetes controlled? Is there hypothyroidism controlled? Is there obesity controlled? When you go through surgical training, you're taught to optimize your patient. Now, if it's an emergency, well, optimization is out the window. You just do the best you can. But if it's elective or semi-elective, we know you don't heal well if your hemoglobin A1C is through the roof because your diabetes is totally out of control. We know, if you're a smoker, that you don't oxygenate your tissues very well. And if we're going to be transposing a flap, a skin flap, a muscle flap, it has diminished blood supply and diminished oxygen for a while until it acquires more oxygen when it's in the healing process. But if you're a smoker, if you're severely anemic, if you have some collagen vascular disease, that wound's not going to heal very well. So optimizing patients is vital. And people who just kind of plunge on through, they fall into big traps, which actually brings up a really good topic. I once talked to one of my residents about this, and that is one of my residents once said, "What would you tell young doctors to be successful?" And there's two topics there: how to say no. I think no is probably the most important thing you can know about and embrace in life, but particularly as a cosmetic or plastic surgeon. No to patients. I can't operate on you. You're not a good candidate. But the trap people fall into, particularly these days, or maybe at any time, is you go through a lot of years of training. I went through I graduated high school, 4 years of college, 4 years of med school, 6 years of general surgery training, 2 years of plastic surgery training. My wife has known me since I was 15. We're married 42 years. She says, "Are we ever going to be able to pay bills and live reasonably?" Because we both came from pretty humble beginnings. You get out of training, and these days it's a little bit shorter. And it's like, oh my gosh, I'm making a good living now. I want that Maserati. I want that Ferrari. I want that house on the golf course. And okay, I say to my residents, don't fall in that trap. Live humbly, at least for a while, because it all sounds and looks good until your income and your expenses are starting to get, instead of having a good margin of income, it's starting to get closer because you're living way over your means, and you have to make that car payment and that house payment, and you bought your spouse, a $20,000 watch, and let's be honest, we make a lot of money. And then patients come in, and this is where this idea of retail medicine, patients come in and they say, "Oh, I want a tummy tuck." And in your mind, you're saying, she's not a great candidate, but it's money. I've got bills to pay, and I got kids that want this, and houses, and my second house, and my cars, and blah, blah, blah. And you start doing things you shouldn't do. And then you get a bad result, and then you get many bad results, and then it kind of gets known that you don't get very good results. And guess what? Your practice starts going in a bad direction, let alone what you've harmed patients, and it sets you off in a horrible direction. So you got to keep on doing the right thing, no matter no matter what's going on, the economy goes down, there aren't as many patients because, we're at the vagaries of the economy to some extent. In certain practices, I've been very successful, but you have to watch yourself. It doesn't matter what's going on in your personal life. You have to do the right thing because it's people. You'd think that would be obvious, but plastic surgeons in particular, but doctors in general, probably lawyers and everybody else, fall into that trap. We're human, right? We fall into that trap, and it's insidious and it's scary, but you just got to keep it.
Yeah, for sure it happens in every single profession. The more successful you get, the bigger the ego is, payments, expenses. So everything should be well balanced in life.
Exactly right. Well said. I don't think I can make that better. Live a balanced life. Live within your means. Be humble. I'm so grateful and so fortunate from where I came. I'm a first generation American. My father came here when he was 13 from Poland. I'm so grateful for what his life has given me. I mean, don't get me wrong.
You work hard for it too, yeah.
I think I deserve it, but you still got to keep things in perspective, right? So.
Yes. So let's touch up a bit on tummy tuck complications and things that happen. So what are some of the most common complications that patients experience?
So they experience scars that don't look very good. They experience scars that are too high on their tummy because they're not planned well. And they just mark them and they do it when they close, they're under tension and they pull up because of the way you planned your surgery. A poor scar around the belly button because, and no attention to detail, planning, reading what other people do. We've got a great opportunity to read all these articles and see what other people do, go visit what other people do. The most devastating one is the tissue dies. Okay. And I think we're going to post one on this here pretty soon about one of my cases. I posted one last year of someone that came to me. We all see these. Someone does a tummy tuck, and that big flap of skin that we're going to pull down has a very diminished blood supply. If it's under too much tension, if the patient's a smoker and they didn't, stop smoking or they go back to smoking. I've had patients wear a belt too tight because they are really proud of their results, so they're wearing the abdominal binder super tight. That will diminish the blood supply, and you'll have an area that necrosis that dies of its skin. It could be little bitty along the wound, which will make a poor wound, or it could be bigger. I had one that was about 7 by 8 centimeters or so. And a big area of skin just died. And I think it's heartbreaking. It's terrible. And whose fault is it? Well, besides that, because it can be the patient's fault. They don't drink enough fluids. They're drinking a bunch of coffee. This is a diuretic, so they don't have enough fluid on board. Maybe they're smoking, or maybe you closed it a little bit too tight, or maybe they're a little bit older and they have high blood pressure. The one that I think we get in trouble with most often is lipoabdominoplasty. So we're liposuctioning the fatty tissue of the abdomen because it's a little bit too full, maybe in the upper abdomen. Sometimes people carry it up there. And when we pull that skin down, it tends to thin out, but it's still too thick and it's not going to give a very attractive look. So we're lipoing it a little bit, which is very safe unless you overdo it. And if you overdo it, then the blood supply to the end of that flap gets diminished and you can have it die. And I had one of those just about a year ago. And I don't think I've ever had one quite like this. And there's not a lot you can do except just let it heal in. Make sure you don't get a secondary infection, monitor them carefully, see them frequently as I did. And then it heals in. And then you have to wait. And there's a trap also. You tend to get pushed by the patients. Oh, you got to fix this now. You got to fix this now. You don't want to jump in too early. There's a period when there's a lot of vasculature and it's going to bleed like crazy. And then you're going to have a lot of scar tissue. So you really have to sort of just kind of wait. It's going to be okay. Keep them closer. Hug them a lot. I hug a lot of my patients. And then when she was about a year out and the tissues were nice and soft and supple, I took that area out and I re-advanced skin flaps from the side. And she wound up with a fine line scar from her belly button all the way down. But if we look at her pre-op pictures, it's a vast improvement. She says, I'm cool. Thank you for repairing me. Which brings up another topic. Who pays for all this, right? Who pays for complications? Who pays for unfavorable results? That's a whole interesting conversation. We can talk about it another time. But that's an interesting dilemma, both for surgeons, for patients, for everybody, because complications happen. I got to touch up this. I got to touch up that. We have to do surgery again. And how do you handle that? So,
thanks for listening to part 1. If you're interested in hearing more behind the scenes about plastic surgery, listen to part 2 next.